I'm Dr. Sri Banerjee, core faculty for the College of Health Sciences and Public Policy at Walden University. And I wanted to go over a trial a clinical trial that took place about 5 years ago or so. And this was known as the CANTOS Trial. Recently I went to a heart and diabetes conference in Philadelphia and got a rare chance to meet some of the forefront experts in the area of inflammation. And one of those individuals is Dr. Paul Ridker, whom I wrote about in the dissertation that I had completed, and I actually finally got to meet in person. Anyway, this CANTOS trial was in fact run by Dr. Paul Ridker, and in that, for the first time, he showed that there's actually, if you target inflammatory biomarkers, inflammation, and this is a biologic agent, canakinumab, and I've actually written about biologic agents and the effectiveness against diabetes by targeting the inflammation. However, this is a different scenario. A similar sort of situation is taking place, and you have interleukin 1b, which is a significant marker for looking at inflammatory reaction. So biomarkers are actually looking at some of the signs of inflammation. It's not directly a byproduct of inflammation. So initially there was a lot of discussion about what it actually does to inflammation. The first actual trial was the Jupiter trial, and there was some lack of clarity in that area. So now in the CANTOS trial that was made clear. And this is why this is an American Heart Association commentary on the original trial. And this is one important step for clinical cardiology, but a giant leap for vascular biology. So in different ways, inflammation affects the vascular system in different ways than cardiology. So taking a look a little bit more about what were some of the things that were lacking, but in order to make sure to know that, I think it's important to go over some of the findings. So let's take a look at those. To be included in the trial, each patient needed to have residual inflammatory risk, and that makes sense because we want to see how much reduction there is in inflammation. So the minimum standard of care therapy, that's important. The treatment was administered quarterly at 3 different doses. So it was on 50, 150, and 300. All doses significantly lowered the inflammatory burden, a 26%, 37%, and 41% reduction in C-reactive protein, and importantly had no impact on low-density lipoprotein cholesterol. So this is interesting because we have been taught in medical school that LDL is the only measure of inflammation. However, there's a lot more going on at the physiological level. And so when you have inflammation that is addressed, then a lot of times that is not shown in the LDL measurement. There was actually a reduction in C-reactive protein, importantly had no impact on LDL. However, only the 150 milligram dose succeeded in reducing the primary and point non-fatal MI, stroke, or cardiovascular death. 15% meeting the trial's pre-specified significance threshold of 0.02. And so these are statistically significant and important to keep in mind when you're prescribing or doing research in this area in inflammation. So canakinumab was shown in a median 3.7 years follow-up. There was a reduction in risk. Interestingly, this outcome was primarily the result of reduced recurrent MI. What's not there is that understanding the lesions that are within the body, within the vascular system. and to understand precisely where those lesions develop and the plaque develops, and if statin therapy and the mean LDL was relatively well controlled, and that was shown in the CANTOS trial. So in CANTOS, 91% of patients actually were on statin therapy, and the mean LDL cholesterol were well controlled. So most of them had 82 milligrams per deciliter. 82 is actually low cholesterol. Current literature would suggest that these factors may skew these patients to be at relatively higher risk for plaque erosion rather than rupture. Further evidence for this trend may be gleaned that from the more statistically robust results when unstable angina with urgent revascularization was included in this analysis, suggesting that partially occlusive events like non-ST segment elevation MI and unstable angina may have disproportionately benefited. So there's a lot going on here, and sometimes some of the sample is overrepresented and others are underrepresented. I hope this has given you some insight. If you want to take a look at this article, actually the original article is important. This goes through some of the other areas. Let me read those out to you. Preclinical study of residual inflammatory risk, determining the mechanism of the benefit, and then avoiding the adverse effects of anti-inflammatory therapies, and then identifying responder from non-responders, looking for benefits to other disease contexts, and that's the end of it. So go through this article. I recommend Baylis et al., and the name of the article is the CANTOS Trial, One Important Step for Clinical Cardiology, but a Giant Leap for Vascular Biology. Thank you for listening.